Welcome to the AJNR podcast. I'm George Vilanilam, the Associate Podcast Editor. My article for today is titled Indeterminate T1-Hypointense Spine Lesions, the Prevalence of Malignancy in the Absence of Aggressive Imaging Features, by first author Barkovich. Let's talk about an imaging finding that we encounter not uncommonly. You're reading a spine MRI and there is a small vertebral marrow lesion. It's low signal on T1 weighted imaging, maybe a little bright on fluid sensitive sequences, but there are no clearly aggressive features. And then comes the question, what do we do with it? Do we call it indeterminate and recommend follow-up? Do we get a CT? Does the patient need another MRI and another MRI? And perhaps more importantly, how worried should we be about malignancy? And that's the clinical dilemma this study tries to address. We know that intrinsically T1-Hypointense vertebral lesions are almost always benign, outside of the uncommon hemorrhagic or proteinaceous metastases. Low T1 signal lesions, however, are much less straightforward. The differential is broad and includes benign osseous lesions, degenerative disease, focal red marrow metastatic disease, and much less commonly, primary aggressive or malignant bone tumors. The Society of Skeletal Radiology introduced the Bone Reporting and Data System, or bone RADS, in 2022 to provide a framework for managing incidental bone lesions. But those guidelines were not specifically designed for the spine, and there has been relatively limited validation using MRI. And more importantly, there really hasn't been any good longitudinal data telling us what happens to these indeterminate low T1 signal vertebral lesions over time. So the authors asked a very practical question. When a vertebral lesion looks indeterminate on MRI, but lacks aggressive imaging features, how often does it actually turn out to be malignant? This was a retrospective study of spine MRI lesions performed between 2017 and 2025, in which an osseous lesion had been specifically reported as indeterminate. The authors initially reviewed 538 exams with 278 lesions ultimately meeting the inclusion criteria, as you can see in Figure 1. Patients with known osseous metastatic disease were excluded, and for each lesion, the authors evaluated the MRI signal characteristics and available follow-up imaging. And the lesions were classified according to their eventual outcome, such as stable for at least 2 years or unchanged on shorter follow-up between 2 and 24 months, or characterized as benign or degenerative on subsequent CT or MRI, or ultimately malignant. The authors also stratified patients according to their cancer history, including those with no known malignancy or known malignancy without metastatic disease, and patients who were subsequently found to have metastatic disease. The key findings in this paper was fairly reassuring. As you can see in this figure, among the lesions with follow-up, 55% were stable for at least 2 years. Another 33% remained unchanged during shorter-term follow-up, and about 10% were subsequently characterized as typically benign or degenerative. And out of the entire cohort with adequate follow-up, only 3 lesions, about 2%, were found to be malignant. But I think the context of these 3 lesions is even more important than the 2% number itself. All 3 represented new bone metastases in patients with known or concurrently diagnosed metastatic cancer. There were no primary malignant osseous tumors identified in this cohort. So in a patient without extraskeletal metastatic disease and without aggressive imaging features, the likelihood that one of these indeterminate vertebral lesions represented an occult malignancy was extremely low. So what did the malignant lesions look like? This was also an interesting imaging pattern among the 3 malignant lesions. All 3 were isointense to skeletal muscle on T1 weighted imaging and hyperintense relative to marrow on STIR imaging. As you can see in this figure, I think figure 2 depicts a new metastatic lesion in a patient with metastatic urothelial cell cancer of the bladder with new sclerotic lesion on a restaging CT. So the sagittal T1 in A and the sagittal STIR image in B and the sagittal T1 post-contrast with fast saturation in C show a T1 isointense, STIR hyperintense enhancing lesion within that L4 vertebral body designated by the white arrow. The background T1 marrow signal is diffusely low, as you can see here, and likely because of active treatment. On image D shows a subsequent fused axial PET-CT image, and that lesion demonstrates FDG avidity consistent with osseous metastasis. So what does this tell us? For me, the practical message from this study is that clinical context matters tremendously when we encounter an indeterminate low T1 signal vertebral lesion. If the patient has no known metastatic disease, the lesion lacks aggressive imaging features, and there is no other reason to suspect malignancy, then the probability of that lesion representing cancer appears to be very low. Conversely, in a patient with known or concurrently diagnosed extraskeletal metastatic disease, an indeterminate vertebral lesion deserves considerably more attention. And I think this distinction matters because reflexively recommending follow-up imaging for every indeterminate marrow lesion can create a cascade of additional MRIs, CTs, patient anxiety, and cost with potentially very little clinical benefit in a genuinely low-risk population. The authors also raise an important question on whether the existing bone reporting and data system follow-up recommendations are appropriate for these incidentally noted spine lesions. The epidemiology of vertebral lesions is somewhat different from that of incidental bone lesions elsewhere in the skeleton. In the spine, we encounter a large number of benign abnormalities and metastatic lesions, while primary malignant bone tumors are exceedingly uncommon. And this cohort reinforces that point that there were no primary bone malignancies at all. Because of this, the author suggests that a one-size-fits-all follow-up strategy may not make sense. So for patients with a meaningful concern for metastatic disease, they suggest that a short interval follow-up at around 6 to 12 weeks may be more useful than waiting for the longer intervals proposed in existing guidelines. And on the other hand, in a low-risk patient without aggressive imaging features or extraskeletal metastatic disease, follow-up imaging may not be necessary at all. Overall, I found this to be a very practical paper for anyone interpreting spine MRI because it provides some actual data for a dilemma we encounter all the time. The key message here, in my mind, is that not every T1-Hypointense vertebral lesion needs to generate an indeterminate finding and another imaging recommendation. Rather than focusing solely on the fact that a lesion is T1-Hypointense, we should integrate its imaging appearance with the patient's overall oncologic context. And in this cohort, malignancy was uncommon, and importantly, every malignant lesion represented metastatic disease in a patient with known or concurrently diagnosed extraskeletal metastatic cancer. And I repeat that there were no primary malignant bone tumors. Ultimately, this study challenges the reflex to hedge on every indeterminate vertebral marrow lesion and reminds us that our follow-up recommendations should not be driven by just the lesion itself, but by a combination of imaging features and clinical context. That's all I have for you in this episode of the AJNR podcast. I encourage you all to take a look at that complete article in the AJNR journal. Thank you.